Unconscious patients sometimes regurgitate stomach contents, a mix of hydrochloric acid and partially digested food, which can be lethal if inhaled or aspirated into the lower airway. It takes very little stomach acid to cause a potentially lethal pneumonia, so make opening and clearing your patient's airway your first priority. Immediate removal of any blood, vomit, or secretions or foreign material is essential to your patient's survival. There are many types of suction units available to accomplish this job. Each unit consists of the following: a suction source, a collection container, thick-walled, non-kinking, wide-bore tubing, rigid or hard suction tips, or flexible, soft suction catheters. Suction units can be either portable to be brought to the patient's side or mounted in your rig. Mounted or on-board suction units are installed in the ambulance, usually near the head of the stretcher. Portable suction devices can be taken almost anywhere. They may be electrically powered, manually powered, or powered by oxygen or air. Whatever suction device you choose, it must have enough vacuum pressure to suction both large amounts of fluid and chunk-sized material, such as food or broken teeth. Tubing and catheters should also be able to accommodate large pieces of particulate. You should also anticipate the use of suction well in advance of its actual use. Running back to the rig for a suction unit when you need it is unacceptable. The most popular type of suction catheter is the rigid pharyngeal tip, also called the tonsil tip or Yankauer catheter. These catheters have a hole in the hard plastic tube that allows suction only when the hole is covered. They are typically larger in diameter than French catheters and can pick up larger debris than their softer counterparts. However, as their name implies, they are rigid and can cause oral trauma if not measured and used correctly. Suctioning involves the removal of body fluids and materials from the airway. Patients may cough, spit, and spatter, sending the vomitus or regurgitation your way. Therefore, it is essential that you take full body substance isolation precautions. You should also overestimate the possible use of suction. Always have a portable suction unit at the side of any patient who could vomit or have secretions in his or her airway. At minimum, any call that is dispatched as unconscious person, person down, cardiac arrest, or difficulty breathing should have suction brought to the patient's side. Be prepared to use the equipment. Listen and look for signs of aspirated materials. In unresponsive patients, you may hear a wet, gurgling sound in the airway. In some cases, you can see materials and/or fluids in the mouth. In other cases, you may hear a retching type sound just prior to regurgitation. All of these are indications that the patient will need immediate suctioning. Apply full BSI precautions. Assemble suction equipment and check to see that it is working. Place yourself at the patient's head. Turn on the suction unit. Place patient on his or her side or turn their head to the side if possible. If spinal injury is suspected or unknown, maintenance of C-spine stabilization is critical. Open the patient's mouth using a cross-finger technique. Remove any foreign material that may be in the mouth, such as chunks of food, broken teeth, grass and dirt, or even an ill-fitting oropharyngeal airway that may have been placed earlier by another provider. Slowly insert the catheter into the mouth with the curve following the anatomical position of the mouth. Place the Yankauer so that the convex side is against the roof of the mouth. Insert the tip to the base of the tongue, but no further, to avoid stimulating the gag reflex. If a gag reflex begins, pull back slightly. Begin suctioning by placing your finger over the hole in the catheter tube. Move the suction tube from side to side in the oral cavity to pick up as much liquid and solid matter as possible. Never suction for more than 10 to 15 seconds at a time to prevent hypoxia. Do not suction for more than 5 seconds in children and infants. Instead of counting out 15 seconds, you can just take a breath and hold it before beginning to suction. When you need to breathe, the adult patient probably does too. If the catheter or tubing becomes clogged with materials, use sterile water or irrigation solution to clean or clear the catheter and/or tubing. Allow a few seconds between suctions, giving the patient time to relax. If necessary, ventilate between suctioning attempts. Monitor for signs of hypoxia during suctioning, such as skin color change, anxiety, or change in level of responsiveness. Be especially aware of vagal stimulation in infants or children, which causes bradycardia. If a gag reflex happens during suctioning, it is usually caused by a catheter that is placed beyond the base of the tongue. The suction catheter can be measured the same way an OPA is measured, from the corner of the mouth to the angle of the jaw. This should ensure that you are not reaching beyond the base of the tongue during your suctioning attempts.